Today is our second Rural Health Virtual Learning Series. I want to say thank you again for being here. As a reminder, this is a virtual learning series hosted by Texas State University's Translational Health Research Center. My name is Cody Gould, and I'll be one of your co-hosts today. Today is our second session of this three-part virtual learning series, all based around rural health in Central Texas. The goal of this series is to highlight community research and programs to open up the discussion around how to enhance impact in rural communities. Now I'm going to be passing it to my co-host, Dr. Elizabeth Ekren. She has an amazing session planned for you today, and without further ado, I'll pass it to Elizabeth.
Thank you so much, Cody. I really appreciate that. So I want to give just a very quick snapshot of who we are at THRC and why this project matters to us. So the Translational Health Research Center, or THRC, at Texas State University is one of 9 university-level research institutes here, and we really focus on impactful, innovative, and interdisciplinary health research and community work that's done with communities, not just about them. And so in our particular role, we work very closely with faculty, students, and community members to make sure that we're doing research with relevance and kind of research that can be translated to the real world to kind of drive real world impacts. As Cody said, my name is Dr. Elizabeth Ekren, and I will be facilitating today's session. I am the lead researcher on THRC's rural health work. I'm an associate here at THRC, and my background is in development sociology. So along with the rural health work that I do, other work that I do at THRC kind of focuses more generally on how qualities of people and the places they live shape different kinds of health outcomes, and how kind of understanding these community dynamics can help design interventions that work. So just a brief session overview for you today and kind of what we hope to accomplish. First, we really want you to learn from the case presenters we have here today about kind of the specific programs that they've overseen that have targeted both systems level and kind of community level interventions to really improve a variety of health outcomes in their communities and their rural health systems. And we've left time at the end of their presentations for everybody to discuss questions, strategies, and context from those case presentations. So today is an ECHO session, and the kind of theme of ECHO is that all teach and all learn. So we are really hoping that time we have saved after our case presenters can be used in a very dynamic way for you all to just, like I said, ask your questions, share your experiences, and dialogue back and forth with our wonderful case presenters. And, really ultimately, we hope that everybody can come away with some specific ideas that they can consider implementing in their organizational context. So I am very honored to introduce today 2 case presenters who are both national award winners in the space of rural health innovation, and both truly offer a wealth of experience to share with you today. Our first case presenter is going to be Mr. Adam Willmann, who's the president and CEO of Goodall Witcher Healthcare System in Texas. And then our second presenter is joining us actually from Mississippi. Her name is Miss Joanie Perkins, and she works for North Sunflower Medical Center in Ruralville, Mississippi. So I'm going to let each presenter briefly introduce themselves. I'll have Adam please briefly introduce himself first.
I'm Adam Willmann. I'm the president and CEO of Goodall Witcher Healthcare. I've been here for approximately 13 years now. And I was also born and raised in this town and born in the hospital that I serve. And I'm very excited and honored to be with y'all today.
Thank you so much. And then Joanie?
Hi, good afternoon to everybody. My name is Joanie Perkins. I'm the Chief Compliance Officer at North Sunflower Medical Center, a 25-bed critical access hospital in the heart of the Mississippi Delta, where we are surrounded by opportunities to improve quality of health in rural Mississippi.
And then before we get started, I'm actually, I'd love for our project sponsor, Mr. Kevin Lambig from the TLL Temple Foundation, to just offer a few words. None of this project work would be possible without the generous support of the TLL Temple Foundation, and it's been a great learning experience just working with them and their portfolio of projects. So if I could just let Kevin say a few words, that would be wonderful.
Thanks, Dr. Ekren. That was nice of you to, Joanie, you hit the nail on the head. I love the way you described that. You said you have opportunities And aren't we right now in an opportunistic world that we're living in right now, right? I mean, we hear all the news, we see what's going on out there. Obviously, we're in the state of Texas where we have opportunities to ensure that we keep healthcare access to our residents. We heard just this last week that another hospital closed there in Wichita Falls. Cal West closed its doors. A few months earlier, the Midcoast Hospital in Trinity, Texas closed. That gives us 25 hospitals that have closed in Texas since 2010. And yet today, we have amazing work that's being done throughout the state of Texas, especially at our small critical access hospitals, which Adam and Joanie lead, where heroes are going to work every day to ensure that the mission still gets done and that people have access to quality health care right where they live. This was an amazing project that Texas State came to us with as we look to see where it was that people went to get their care and what mattered the most to them. So I'm excited today to hear both from a good friend, Adam, and from a great leader at NRHA with Joanie to hear about these great cases that they're going to present today and to keep the positive attitude going, even in these times where we're hearing so much negativity. And just to reemphasize the question and answer, we want to hear your questions. We want your comments. So please keep putting those in as the session goes on so that we can get to those later today. Thanks, Dr. Ekman.
Thank you so much. I really appreciate that. And we're just looking forward to hopefully giving you a great session today. So with that, I'm going to turn it over to Adam, who's going to get us started. And I will say we have time blocked for questions, experience sharing, and dialogue at the end. So if you do have questions, feel free to save them to that time or document them in the chat, and we'll just have a record of it and we'll get to it during our dialogue session. So with that, go ahead, Adam.
All right, I'm going to share my screen. So my impact in getting our local community to really engage into our hospital goes back 13 years ago when I first got here. And it's really why we're here today and as strong as we are here in good old Witcher. Nope. Let's see, now I'm having problems. There we go. All right, so Good Old Witcher is a 25-bed critical access hospital. We are located 35 miles northwest of Waco in Central Texas. We operate 2 rural health clinics. We'll have a third one coming online in the first quarter of next year. We have now 25 full-time medical providers. We do home health, and we also have a fitness center. So that's kind of who we are and what we've done. In the beginning, when I arrived, we had low patient satisfaction. We had a high out migration. What was really hurtful is poor community engagement and public perception. And what I mean by that is you go out into public and you hear the comments, I wouldn't take my dog there, something happened. People just weren't coming here. And everything kind of showed through the low census and the height of flu season that year. I walked in, we had three patients in flu season, which is now uncommon. And more importantly, we only had 2.9 days cash on hand. So kind of 13 years ago, we would probably be the poster child of the next rural hospital that could be or should be closing very soon. So we knew at that point we needed to get the community involved, see what they wanted in their healthcare, and try to change where we're at. So a lot of the changes we did, we started meeting the community in their space. And what I mean by that is I started volunteering. I became on the chamber board, got into Rotary, started calling bingo at a not-for-profit here that does a bingo night. So I call bingo. It's probably the best thing that I'm good at is calling bingo. And really kind of met the public where they are and asked them their perceptions, why, let them kind of tell us what was going on. Go to the barber shop and have those conversations with the guys. And one of the comments that really stuck to me is, Adam, we're closing. They just brought you in so that you would be the downfall guy and not the previous administration and board. And I kind of took that to heart. But I also knew walking around, we needed a lot of internal culture changes. We complained about getting an admission. Again, we only have 3 on the floor. Why are we complaining? If we don't have patients, we don't have jobs. And really kind of taking both of those together is developing that good old saying, perception's reality. Whether we like it or not, perception's reality. And we knew we needed to change the perception. And so we started getting a lot more feedback. But not just getting the feedback, me and the administrative team, who I've have some of my team members have been with me since the beginning, we started taking those perceptions and utilizing those complaints and really kind of changing the way we were doing things, even if it wasn't really changing the outcome, or maybe the outcome was changing, but how we were doing it wasn't really different. It was just slowly changing that perception. We started utilizing community health needs assessment. And I know not every hospital may do that. I know if you're a foundation, or if your hospital has a foundation, you do need to conduct those every 3 years for our IRS. However, I have found that those community health needs assessments is a really good way of keeping the public engaged. And I kind of go back because of, and I'm going to talk about 13 years ago, then in 2018, we went for our district and we were in the public at all times doing town hall meetings, listening to what they wanted, what they were doing. But we've also did a lot of groundwork prior to going to the district to change some of those perceptions slowly but surely. And following with the health needs assessment, we brought that internally and changed our mission, vision, and values. We created that with our employees. It wasn't the board at the time. It wasn't administration. We did an employee engagement survey, which we do every year, but we asked them what their mission, vision, and values really were. And we adopted what our employees saw that we should do. And then we made a huge change in our marketing strategy. A lot of it being more engaging with testimonials. We did away with the internal marketing, and we actually hired on a marketing firm that had all of the various modalities for marketing. You got your billboard people, you got your social media people, you got your testimonial video. So we really made a lot of different changes with the perception by engaging our community. And I can tell you, if we had not done that, the district would not have passed. We really engaged them. What do you want from your healthcare? What do you want us to provide? And to this day, we still do community health needs assessment. We actually get a lot more people involved. Quick story, I was calling bingo this past last Tuesday. It was a wonderful bingo. It's called Oktoberfest bingo. And yes, as a German in the Norwegian capital of Texas, I do have lederhosen. So I do take it all in stride. But after bingo, I had 3 people come up and said, hey, why can't we provide this? What are we doing for this? I think our community needs this service locally. And it is, 2 out of the 3 weren't bad ideas. And so we're able to really engage them. A few of the other things that we've really done to engage our community after the hospital passed, again, we had a better perception, because after they passed that district, it became their hospital. It was there. They feel, the taxes that we collect is less than 10% of our annual budget now. But they feel an ownership to us, which means I spend a lot more time in the grocery store than I used to. But we are now the asset to a community, not just there. And we've been able to get them involved in our strategic planning, which again goes back to, hey, what about these services? What about those? And when we're able to really implement what they are saying and doing, it's really a tangible outcome. Currently, because of that, our volumes almost in every department have doubled in just the last 4 years. Our cash on hand is no longer at 2.9. It's actually closer to 90 days on hand. And again, none of this would be achievable without engaging the community and having them do a lot more or give a lot more. I always think about chambers and other associations, whether it's the NRHA or Torch, you only get what you put into it. And that's what we really started telling our community. We can only do what you're willing to put into it. And so because of that, all of that's changed. I always like to talk about meeting our community where they're at. Well, now they're coming to our cafe every morning, every day for lunch. We've become a central restaurant hub in the metropolis of Clifton. And again, I take my time to walk through there, to communicate, to talk, see what's going on. And I really think of kind of where we're at. We wouldn't be without that engagement of really of our community saying, yes, they are an asset. We need it to be an asset. What can we do for you? And so it's also the best marketing when you have your individual who was 13 years ago, I wouldn't bring my dog there, now is solely coming here. I won't go anywhere unless you tell me. They're utilizing the ER, the physical therapy, our doctors. And Clifton is a retirement community. And so a lot of people who move into the Clifton area are from the Dallas, Fort Worth, maybe Austin, somewhere where they're moving out of a big city. A lot of times they still travel for their healthcare needs. And really, we kind of even engage those individuals of saying, look, don't change your doctors, but come to our clinic one time while you're still well. Let's do a visit so we can get your allergies. We can have a baseline on your health. And more importantly, we have a medical record on you. So when you're out on your farm and you get hurt or snake bit or something, we have a record when you come into our ER, and then that basically has engaged this new person. Okay, I can do that. I understand the importance of that, of having an active medical record, because if you are a female and you're resting upon your husband to know your health care, they forget to go get milk at the store, and that was the only thing they were supposed to get. Here's a way that you don't have to worry that your hands are in, or your life is in the hands of your husband, because that's not a good place to be. If well, that's what I tell my wife. That's not where she wants to be, is me telling them when they're of her allergies or anything else. And so we've really kind of just get into our community and stay there. And I found in the beginning it wasn't fun, because again, it's all the bad things. And then after about 8 years and the district, we really were able to now form a much symbiotic relationship. People are telling you, you're doing a good job. Hey, what about this service line? What about that service line? And sometimes it's one that you may not realize, or can we even do? And so we continue with our outcomes. We're the go-to for the health resources, whether it's our lunch and learns. Importantly, right now, we're about to have open enrollment for Medicare and Medicare Advantage. This is a way they come to us. Like, what Advantage plans should we not go to? And maybe the answer is none of them. Maybe it's traditional, but they're really coming to us. We're having a lot more people come to health fairs, again, interacting with us on social media. That community involvement is so huge to us where they are. Currently, we have turned to 2.9. As you heard, we are a lot better. We're building a third rural health clinic in a neighboring town. We're currently putting a MRI in-house because the community really came and said, I'm tired of the 18-wheeler MRI parked out back. I think we could get better technology. What do you need to get that done? And we're getting it done. Our clinic has grown so much. They keep wanting more specialists. We have no more clinic space for them. So we were able to go and close a service line. We used to operate a nursing home in our hospital downstairs. We closed that last October, and we're remodeling that just for specialty care. And we've gone out, and now we've hired uh, through our community. We've been able to hire a podiatrist, which was very much needed in our rural area. We had some issues with radiology reading and being dropped. We've now hired a full-time radiologist on staff and just solely doing that. And that's been huge because of networking through our community and their involvement. We've hired a cardiologist for part-time because it was something that just really came together with community saying, hey, I talked to my doctor. Yes, he's retired, but I think he'll come work for you. And we've been able to just continue to grow and become stronger. And our biggest issues we have now are we're out of space on everything. Our hospital is 73 years old, or I mean, 53 years old. It was built in 72, and we're out of space. And so now the community is coming to me like, hey, what is it going to take to build a new hospital? What can we do to start thinking about building a new healthcare system in Clifton to meet the demands the next 50 years? That is nothing I would have thought I would have ever heard, seen, or get to be a part of, is community people coming to me telling me we need a new hospital, which I kind of already knew. And so all of this, I feel like the success of Goodall Witcher has been just really working with the citizens of Bosque County, and even those that will come to me and say, I voted no for the district. Thank God there was a lot more people smarter than me. What can we do next? And so that is what community involvement does. And honestly, it's saved this hospital over the last 13 years and really has put us on a trajectory into the future. I would tell you as a CEO, again, the hardest thing is to be everywhere for everyone and hear nothing but bad things. But through that time, that effort, that listening to them at the, coffee shops, barber shops, grocery stores, and then making those slight adjustments with the admin team and our employees starting to see that, feel that they're tired. They were getting beat down in the beginning. How do we change that? Well, let's do a better job by the perception of it, which it may not change much of anything. And so I do think Goodall Witcher is here because of engaging the local community and really getting them involved into what they want to do. So that's kind of the overview, kind of the bigger thing. It's not really just how we've been able to be successful in one service line. It was the whole hospital, and it can be done. It's just a lot of work on your team and a commitment that you got to make that you want to be better. So I know we have questions afterwards, but I know we're also on a short or strict timeline. So I will unshare this hopefully and let it go on to the next success story.
Thank you so much, Adam. I really appreciate that, and I'm excited to move on also to Joanie's presentation. I just wanted to offer a few thoughts before we transition. I think one of the things that has resonated most with me as I've learned more from Adam is just kind of the multi levels and the multi layers of solutions that Adam and his team have been able to pursue. So, oftentimes I think we think a lot on these big ticket items, big ticket policy changes. And I think that those are important, of course, but I also think that it's wonderful to be able to think about what levels can we engage, and can we find different entry points and possibly kind of lower barrier to entry points, such as cafes or community surveys, or kind of just engaging people maybe at a more individual level, because that ultimately filters up, I think, to those bigger ticket items, and then can kind of provide the momentum, the justification for some of those bigger ticket items along the way. So that's been one of my favorite things to reflect on. And I know Joanie is going to share a similar case presentation about a program that was really very patient oriented, but also very much engaging different levels and different facets of the community. And that's led to some really great successes at, again, kind of multiple levels, not just the patient level, but kind of the community and the system level. And so I'm going to turn it over to her now to explain more about that program.
Well, thank you very much. I will tell you that, Adam, you are the first person I have ever heard that enjoys your community health needs assessment. And you are an inspiration to me because we're getting ready to survey right now. So if I remember what the intent of that is, instead of all of the work behind it every 3 years, I'll be a better person for that. So I appreciate that very much. And you come into Policy Institute to advocate for our leaders. I want to see the lederhosen. My maiden name is Krauskopf. So, okay, let me tell you just a little bit about what we did. Here at North Sunflower, we're pretty blessed to have some great partners, and the University of Mississippi Medical Center is one of those. And we were one of the first people they did telemedicine with. And so we were obviously in their thought process when they thought about starting remote patient monitoring some 10 years ago. Fairly new at that point. We were all just hearing about it. So there really wasn't a way to get paid for it. There wasn't any grant funds there, but they were able to pull the right partners to the table to do a Mississippi diabetes initiative. So let me move this out of my way. It was a telehealth initiative, and we wanted to do it well. So they invited their teammate, which is us at North Sunflower, to do it with them. Okay, this is a picture of North Sunflower as it stands today. Well, not today, it's pouring rain, but this is a bell tower here. We built it, our foundation built it. The North Sunflower wall that you see there has naming opportunities on the back. So this is all fundraisers for our North Sunflower Medical Foundation. All of the lights have been named, all of the benches have been named. So that was a great idea for us too. But this is the newer part of our hospital. Our hospital was built in 1950. It's a Hilberton hospital, needed a big renovation. Did a partnership with USDA, hint, hint, Adam, USDA is a good partner. Their community health facilities is a good partner. We did an $8.6 million renovation to our organization, and we partnered with USDA, our own community, and then the hospital put in 2.6. And I don't know why this doesn't want to listen to me. This is one of our ORs. This is suite number 1. And what we always said was if we build it, they will come. So that our Field of Dreams was sort of our mascot throughout the build, because when you do a massive 33,000 square foot build on a 30,000 square foot hospital, it's a big deal. So we had mascots and we had sayings, and we celebrated department by department as we grew it. But we have 4 ORs now, and boy, was that ever true. If we build it, they will come, and we did, and they did. So we have an extremely active OR now. You can see by the size of our suite number 1, this is large enough to do a team surgery in. Our tables were specially installed to hold up to 600 pounds. Our housekeeping people can clean this room floor to ceiling in 15 minutes. And so we can do case after case, but we do have smaller rooms, of course, for our colonoscopies and things like that, because we're a lot into prevention here. Let's tell you a little bit about our town. We are young by population. We are primarily African American. We are proud Delta people who have generations of families living here. I was an outsider. I had someone ask me, I came from the Midwest to move to the Delta here 19 years ago, and I had a guy ask me if I was from Japan. I said, what? Japan? No, I'm from Indiana and Ohio. So anyway, I'm definitely the outsider, but very interested in opportunities for places that have big opportunities. You can make big impacts in places like that. And I was very much called to be here. So here's the hardest part. If you look at the statistics at the bottom of your page, in our county, 29% of our folks are living below poverty. And the heartbreaking part is the 46% of children under the age of 18 are living in poverty. That has a whole host of opportunities right there, because when you say poverty, it's pretty abject poverty here. We have a lot of properties that you wouldn't think need to be occupied, and then you see big wheels out there, and and different things. So we have developed a strategic plan for our town, and I won't go into too much of that because I know Adam did a lot of community engagement, but parts of those are being leaders. Our healthcare organization has several leaders that do all kinds of things, and we work with our schools. We're bringing the Covey program into the schools to the entire county, and there are just a lot of things we're doing there. But these are the things that are opportunities that we are working with. Food and nutrition, yikes. Look at that obesity prevalence. I don't know if any of you are from a place that your county has almost 51% obesity prevalence, but you can see it. And it always struck me as kind of weird when I first moved here because you see people walking everywhere. I mean, people walk all the time, but I found out it's from necessity. They don't have vehicles or they don't have gas. It's difficult for them to get to places. So it's important that we're here. Our critical access hospital is here, and it's important that our rural health clinic is open from 8 a.m. until midnight, 7 days a week. That's important. We need people to come to us. We need to be available when they need us and keep them out of the emergency room. So all those things are opportunities for us. We need better food and nutrition. We worked with PBS and had a group come down here some years ago and took pictures in our local grocery store, which has now changed hands. It's a Piggly Wiggly now. But when they came and did that, I never realized there were 13 different kinds of honey buns in our grocery store. And there weren't any apples and there weren't any oranges. So, I mean, they really brought it to my mind. So we have worked diligently with our grocery store. Okay, we did keep our sense of humor. We had to. You gotta laugh. These stand up big. They were flatter than a pancake here, and this is what you see when you drive anywhere close to our town. And you cannot believe the number of kids that are like, well, how do they keep it cold in the summer and hot in the winter? So I let their imaginations run wild. But we did that with a little local grant. Here's what we did. We didn't have any grant funds. We just had interested people who saw opportunities in a place that needed a lot of help. High incidence of diabetes. If you know Mississippi, we are right on the top with, we in West Virginia and Alabama and Louisiana, we're also used to being in that place and we just hate it. So this was just an invitation to try to change that. And these were our partners. C-Spire provided us with that's our local broadband, and C-Spire provided us with internet access for all of the tablets that we gave to our patients. Care Innovations are the folks who developed the material that our patients would listen to every day on their tablet. GE Healthcare did the tablets. North Sunflower supplied the people, and the University of Mississippi really supplied the experts in telemedicine. So we all had our jobs to do. The governor was really on board. Back when Governor Bryant was here, he was very impressed. That is Dr. Christy Henderson there. She moved to Texas right after this picture. So you guys have a wonderful person there living in great state of Texas. I used to live there. So we had strong input from the governor's office. Now, in the state of Mississippi, our governor runs the Division of Medicaid. Our state was one of the first or the first state to pay for telemedicine visits for our Medicaid population. He got it. He realized how important it was, how this, a lot of people will, I always use this analogy, having the remote patient monitoring program with you and having that is like driving down a 4-lane highway when there's not a cop in sight and you can go as fast as you want. Having the program with you is like having a state cop right on your hind end. How many people are going to speed then? I'm not. I'm going to do what the program says. So that's what to me, it's what it was like. We did have some goals. We wanted to improve diabetes and bring in all of these resources through technology to people. We wanted to be the task force that brought it together for people to show if you build it, they will come. That's really been our theme. We're awful in diabetes. We wanted to get it corrected, and we knew that in Mississippi, we had over 200 rural health clinics. Now, to Texas, that might not sound like that much, but we're a great deal smaller than you are. So that's a lot. So we were in all of these rural areas, and we wanted to be able to control some of the costs and that are associated with uncontrolled diabetes. We saw it in our emergency room. We tried to control it in our rural health clinic. We have a great triaging program. If you show up and you're not critically ill and do our EMTALA screening, we push you right over to the clinic and we get you established with the primary care provider and we start on you right away. We're continuing. We wanted to use the remote patient monitoring platforms. Each participant would come in for a 12-month period. We did 2 periods of 12 months. When you're doing human research projects, you have to have I'll tell you, to get that review board to approve all of our consent forms and everything, I thought I was going to pull my hair out. I was about ready to hire my own, and take off on the project, but I was patient. Our goal was to achieve a 1% reduction in 75% of our patients. And I'm happy to tell you that we not only achieved that, we succeeded that. So it is a proven fact that remote patient monitoring works in one of the highest prevalence areas of diabetes in the nation, with some of the most impoverished people that you can put your arms around. It's all opportunistic. We can do this without tons of money. We got partnerships, and that changed everything. Here's sort of our algorithm on how we did it. We defined our target population, super easy, full diabetic patients. Here were our target population risk factors. They've got to be greater than 18. We want A1Cs over 7. We didn't jump over 9, which is where currently CMS is sitting for our MIPS reporting on patients. It's over 9. And we just wanted people who weren't healthy. So we pulled everybody over a 7. We wanted to make the referrals so that we controlled their primary care. We wanted that. If they had someone else as their primary care provider, we sent letters and got permission from them to take care of these folks during this process. They had multiple meds, whether they were compliant with that or not. Thank goodness for 340B funding and critical access hospitals. We were able to get these people the meds that they need. So we enrolled them into our program, and they all had, at their access, we provided a PharmD, a pharmacist, available to them to help go through their medications, not just with our healthcare team, their healthcare provider and their team, but we also added a PharmD to it, which really opened a lot of our eyes. My biggest problem with the program as it started rolling out were the complaints and the opportunities we had to speed it up, because that initial visit took a solid hour and a half. And people weren't all that pleased. And I know sometimes when you're working directly with the patient one-on-one, they don't feel that time as much, but it was laborious. Some of the patients weren't as educated as you would have hoped to go through all of this training at once. So we ended up breaking that up into 2 sessions. So this algorithm worked for a period of time, and then we had to learn. These are the tests we ran, all these baselines. We actually reviewed all of these prior to and post program. So we definitely have good data. We did all their comprehensive foot exams. We tested their knowledge. We thought that was important. We wanted to know what they knew about diabetes, and so many of them didn't know much at all. We wanted them to have the retinopathy screening, so we wrote a little grant and had a machine right there at our place in our rural health clinic, and our grant nurse would go in and do their retinopathy screening, send it off to an ophthalmologist who would read it, send us back the results, and we had all of that information moving forward. So they all got dietitian care, which was great. and then they received education on the tablets themselves. We did learn a lesson about the tablets. We had to sort of restrict some access of what they could use those tablets for. And some of the people, when they got out of the program, gave us back the tablets. Some did not. So that was a learning curve as well. Now your telephone probably could do all of this easily. After we did their baseline, we hooked them up with a PCP. We talked about food and what they're currently eating and really assessed what they were doing as far as their daily nutritional needs. Based on what they answered us, we did additional lab work, and then we scheduled all of the referral appointments that they needed to become compliant with proper diabetes care. So these people really turned themselves over to us, and we were grateful. We did 100 in each cohort. We had thousands. Okay, visit 4, we repeated the tests, and here's the thing, return the Care Innovations tablet guide. Some didn't want to, even when we shut them off, they didn't want to, but that's okay. And I'd love to play you a little video here, and I'm going to go ahead and let Cody take that over, but I want to tell you first, I'll stop my share, Colby. And this lady is Miss Annie, and Miss Annie was genuine and wanted to control her diabetes, but didn't have a clue how to control it. Her A1C was too high. She didn't have a clue. So we got another person that was in the program, and she is an employee of ours, but she was also in the program. And we called her Oprah Winfrey of Ruralville, because she did such a great job with this particular video. And I will tell you that when we had Commissioner Carr, we'll play the video and then I'll tell you about Commissioner Carr. Please. Thank you, Cody.
Hi, I'm Jackie Collins from North Sunflower, and it gives me great honor to introduce one of our new participants, Mrs. Annie Ford from Beulah, Mississippi. Welcome.
Nice to meet you. Thank you.
Ms. Ford was a patient here at North Sunflower, and she was introduced into the diabetes program. Ms. Ford, can you give us a little insight on what is going on with you since entering the program?
I've learned a lot that I didn't know with the program. I just want to learn what I need to do to take care of me. And this program has been awesome for me. And in these last few weeks, I've learned more than I've learned in the 15 years I've had it. When I was introduced to the program, I was afraid at first because I knew I wasn't like I should be. Okay. But talking to them and they guiding me through this, it all was good. The program itself helps you to understand and know what you're supposed to do as far as exercising, eating, and taking your medications on time and doing the right things to keep you going. And I feel real good now than I did when I first came to the program. And I'm enjoying it, and I love my tablet because it's teaching me a lot.
Is it self-explanatory and easy to use?
Yes, it is. Yes, it is, very much so.
What do you think about the personal assets that you have in the morning, like the questions about your diet? Have you exercised? Have you taken your medication? Do you think that it helps you stay in gear with what's needed to be done?
Yes, I do, because a lot of times you might not think about getting up, checking your sugar, or getting up, exercising, or getting up, eating the right proper meal for breakfast. It does. And when you hear that, you're like, oh, okay, let me go and do this. And it keeps you going throughout the day. Okay. And I love it.
One of the things that I found exciting was one morning I got up and my blood sugar was too low. It was 67, and it warned me that it was low, but it also told me what were the right things for me to take or drink to build it up, where a lot of us might think, well, I grab me a piece of peppermint or a soda, but it specifically told me orange juice would be the best thing to make it right. So to me, it has been an awesome experience. So are you my challenger to get your A1C as great as mine?
Yes, I am going to work on that, because I'm learning now that you can eat anything that you want. Correct. But it's the portion.
That's it.
It's the portion. And now I'm learning to just eat a portion of food and not eating at night, late at night, and all of that. I got up one morning though, mine was too high, and it scared me, but on the same tablet, it told me what to do. So I did that, and I checked it again, and it was back to normal. So I'm grateful to have this program, to be able to be in this program with you all. I'm trying to tell everybody, tell people to come, because a diabetic never can learn too much.
Correct.
And I'm trying to learn all I can learn about doing what I need to do to take care of me.
Well, we're excited that you chose us, and we appreciate you.
And thank y'all for having me. It's great.
Mrs. Ford, I would like to thank you for participating in our program and to let you know that we at North Sunflower are elated that you chose to be one of our patients. I would like to challenge each of you to learn to eat healthy. If there's any information that you need, please contact the North Sunflower Rural Health Clinic, and we would be excited to assist you in learning how to eat healthy.
See why we call her Oprah Winfrey of Ruleville. I will tell you that Miss Annie made such an impression on Commissioner Brandon Carr when he came to visit here, that it was about 9 months later that he introduced the FCC's grant for telemedicine. And obviously we applied, but to be able to get people access, because he saw how much it changed things. Now he's been back to visit again, and another one of the 5 commissioners has been here as well. So small changes, and you see the opportunity, you can do it, even in a tiny rural area. It's important.